All right, so diverticulosis. So diverticulosis versus diverticulitis. So notice diverticulosis is on the GI bleed list and not diverticulitis, because itis is inflammation of the diverticulum, but it's not, doesn't cause bleeding. Right? It's inflamed to the point where it where it compresses the vessels so they don't bleed. Whereas diverticulosis is like these little fun toys. If you've had one of these, right, by the dollar store, by the $5 store, right, and you go in there and you squeeze them. It's cool and cool. It's cool when it's in your hands, but it's not cool when it's in the haustra of your sigmoid colon, right? Your sigmoid colon is going to have a little poppage, a little pop, right, and it's not going to retract back to where it wanted to be, right? So you're going to have this diverticular outpouching. And that's now a prime area, yes, for infection and diverticulitis, but it's a prime area to pop out to the point where we now have a GI bleed that starts ruptured, these little ruptured little microvessels, right? And these are, do people die from diverticula? Yes, they do. Is it common? No, it's like 15 to 20%. So it's really hard to get someone in to fix it right now. You just have to let them know the gravity of the situation, of how much blood is coming out. Okay, but usually they kind of self-resolve on their own. They, definitely be investigated, and they might be scheduled for an outpatient procedure in 2 weeks, right? But if they're admitted to the hospital in the ICU, they should get scoped in the next morning, right? They need to get what done? What's this procedure? It's a banding via colonoscopy. It's the same scope, not the same scope. They have different flavors, but it's a longer scope colonoscopy. But it's the same. They prep it with bands, okay? And they just kind of scoop up the tissue there. Right, take the little outpouching and go in there, and they place a little band around it. Right, scoop it and then put a little band over it. Okay, so about 30 to 65% of our lower GI bleeds. That's an incredible number. Right, and it's a first world problem. It's much more popular in America than it would be in a third world country. It's because Americans like to consume what? Fiber and drink water all the time? No, right? They are very constipated Americans, right? So America, right? They are very constipated, and they are going to be on the toilet, right, on TikTok for 2 hours. They're going to need a PT consult by the time they get off, right? And they are going to be a high risk for diverticula. They're just going to pop out these little outpouchings there as they keep straining, and that's going to then lead to a lower GI bleed or bright red blood per rectum. Is it going to cause melena? No, because the sigmoid is the most popular place for these little outpouchings to occur, because the sigmoid is a smaller tube compared to the proximal colon, I should say, right? So the colon over here is much wider than the colon over here. Right, so it's a higher pressure system. It's like a bottleneck, literally, all right, out the rectum, right, and it's going to cause a much higher pressure, and this is where you're going to get the poppage. Okay, so it is 75% of these are self-limiting, right? So you get this activity happening, you get the lower GI. Ooh, I better let me just rethink my life choices and not spend so much time on TikTok, and then it might resolve on its own 3 times out of 4, right, 75% of the time. But other ones, they can get serious, and they will need to go in for clipping. Usually banding is the go-to one for that. Or if it's really oozy, really bleeding, they could go in there and they can find the artery. All right, let's find a different color. They can find the artery, and they could go in there, and they could go in there, and they go in there, and they can embolize it. And they don't cauterize it, but they go in there via IR, right? And they introduce a little catheter, and they clot it off where the bleed was occurring, right? That's called IR embolization. If it's super serious, right, they couldn't do IR, there's still massive transfusion, they will have to resect the bowel. They'll have to do a sigmoidectomy, right? Is that common? No, but it is very possible for that to happen. And one of the complications of diverticulosis is diverticulitis, because this outpouching is not just for activities, right? It is also a place that bacteria can get in, and they can start brewing in there, and they can start brewing. That's not really a bacteria kind of color. Maybe that's bacteria, right? They can start brewing in there. And the bacteria could cause diverticulitis. So let's put itis in there. Okay, so an itis can occur because of an osis, right? Which one bleeds, osis or itis? Osis bleeds, and itis is the one that has inflammation to the point where it kind of compresses off the vessel. Okay, so bleeding, is it painful or painless? It's a painless bleeding. Is itis painless? No, diverticulitis is very painful, but diverticulosis is a painless bleeding, right? They're not going to seek out help. They're going to seek out help when they have hemorrhoids. That hurts, right? And it's a lower GI bleed, but when you have a lower GI bleed and it's painless, ooh, Must be the beets I ate, right? And then they're gonna hopefully might resolve, but otherwise they might get symptomatic. They might get tachycardic, feel palpitations, get fatigued, and have syncope, and they definitely need to seek out help because now this lower GI bleed is symptomatic. Okay, so here's real life right here. You can see all these little outpouchings, and it pops out, right? That's really, that's pretty significant where the little outpouches occur because of constipation. That's the underlying reason. Okay, as usual with age, because with age you're a little more dehydrated, right? And your bowel is not as spry and compliant as it was when you're younger. So switching over from diverticulosis to diverticulitis, right? So diverticulitis is an inflammation of the diverticula. So we have this outpouching and this oozing. This one here in bottom right corner is osis, right? We have a diverticulosis that occurred, and then with that laid the scene for bacteria to start getting there, and the bacteria and also little hard chunks of stool, right? And they start forming poop rocks, right? So there's an example of a poop rock here in the top right corner, life size, right? So that's a rock that is now that forms. It's called a fecalith, right? Lith being stone, fecal being feces, right? So fecalith forms, right? And it starts rotating like one of the little tumblers, right? You ever seen those on TikTok where they put little stones in there? It comes out like super smooth afterwards. Well, your GI tract's not a stone polisher. I don't know. And it's not a stone polisher, but it'll start, those little jagged fecaliths are going to start rupturing this diverticula, right? And that ruptures and ruptures and ruptures until it starts forming little fistula, right? It forms a fistula between the bowel and the bladder, the bowel and the vagina, or the bowel and another bowel, small bowel. And that's going to cause a lot of pain and discomfort in that area especially, right? And this inflammation locally, that's going to cause a lot of pain in that left lower quadrant. Okay, so again, it's not a cause of GI bleed. It's the inflammation that's occurring. Which one's more serious? Rarely, diverticulosis becomes a serious bleed, but it can. But diverticulitis is much, much more serious because now you can have a fistula growing, and you can't just wait it out, right? You're not going to wait out a fistula to heal itself, right? If you do, you're going to start developing abscesses that are going to start forming there, and as now you have white count elevations, fevers all the time. So it's very, very high risk for it to develop into an abscess and a sepsis-like presentation. Are they super, super sick? Not all the time, but they might need to have some just clear liquids, and they'll definitely get some antibiotics to hopefully calm down this diverticulitis. And if it has perforated, it has formed a significant fistula, right? There's an abscess growing right there, but it forms a significant fistula between the bladder or whatnot, or another bowel. They do need to get surgery at that point to get it fixed, right? Surgical evaluation to resect that bowel. Okay, so that's called a complicated diverticulitis, right? Where we have to get them admitted. They have a fistula. How do we find out that a fistula between their bladder and their bowel? How did they figure that out? They did a what? They did a CT scan, right? So CT scan is go-to test that we want to do. A CT angio is what we want to do for diverticulosis, but a CT just without contrast to see if there is a fistula happening or an abscess occurring is what we want to get for diverticulitis to see if there is a sign of worsening infection or high risk for infection. Okay, you get abscesses and fistula from diverticulitis. Okay, so the diverticula lay the scene for it, and you can have complete bowel perforation, which is never good, right? So bowel perforation leads to what symptoms? GI bleeds? No, it's going to lead to significant infection, right? So significant peritonitis. So peritonitis is what can happen from this guy here, and we'll talk about peritonitis coming up, but peritonitis is when you've ruptured through the bowel and you have perforation. Perforations could happen with peptic ulcer disease. Perforations happen with diverticulitis, right? And that's where you've ruptured through the bowel, and now you have free air in the abdomen. You also have free bacteria in the abdomen. They can form abscesses, or they can form significant peritonitis, significant diffuse board-like rigid abdomens, distended abdomens, and also they require surgical evaluation. It's called an acute abdomen, right? Where they have this serious situation happening in their belly that needs a surgical evaluation to make sure it's not getting worse, right? So there's this old wise tale about seeds in diverticula and diverticulitis that's been completely disproven. That's not a thing, right? So it's fine to have whatever seeds you want. Should they eat like bird seed? No, right? But they can have sunflower seeds from time to time. Should they be like eating sunflower seeds all day long? No, but there's no evidence that a sunflower seed is going to get caught in there and it's to become a fecalith itself, right? The fecalith happens because of a trapped stool more than anything else.
Okay. Now, they're still told not to eat things like popcorn. Is that still
That's
accurate?
Not true. No. So popcorn's fine. All these things are fine, right? All right. So but it's been disproven. There's not any evidence that causes worsening diverticula or diverticulitis. Okay. So we have uncomplicated and complicated. Complicated is where you have the abscess. You have it fistula developing, right? And complicated, you have to start some antibiotics to get that going, and you need surgery to evaluate to see what they need to do. They need to be on the radar so they know it's like, oh shoot, they develop peritoneal signs on my next evaluation. They need me to take them to OR today, right? So we're looking for stability in that diverticulitis. If it doesn't get stable, then they need to go get resolution with surgical input. They might place a drain in there to drain it. There's some other options, less invasive options, especially if they're an older patient. But if it's causing peritoneal signs, peritonitis, they have no choice. They have to go in and resect that area and do a washout and try to fix the diverticulitis. So ischemic colitis. So this is where your colitis, your colon, is ischemic. Right, so if it becomes ischemic, then you're going to lose blood supply, or you're losing blood supply to these areas right here, right? And it's going to start sloughing off, getting necrotic, and it's going to start dying, and you're going to start getting blood in the stool, right? So, and again, the most common sites are right at these areas right here in the little flexures of the colon, and that's going to cause, obviously, bright red blood for rectum. It's not going to be in there for 10 to 14 hours to cause melena. It's about 5 to 20% of your lower GI bleeds. And this can lead to impaired defenses against invading bacteria, right? Because this colon, your large intestine, is sterile or non-sterile? It's non-sterile. So you have all this GI bacteria that's waiting for the opportune time. So this becomes ischemic and necrotic. It's like, oh, shoot. And they're just going to go ahead and translocate across the bowel wall. That's dead now, right? All the forces are dead. And they can then translocate into the gut, or from the gut into the bloodstream. And if they don't do that, they can then start, percolating because obviously the GI tract's not going to be moving great at this point, and they're going to, because of the risk factors for ischemic colitis, so the gut bacteria are going to start producing what they produce best, which is what? What do bacteria produce? Gas, right? So they're going to produce a gas, and that gas you can see on a CT scan, right? You have a pneumatosis. You have venous gas seen on CT scan, right, around the bowel. That's always a worrisome sign. That's never something that you just pass over, right? It's like you need a stat surgical consult. They might need to take out a piece of colon. Something's going on about why is there extra gas here. Same thing, there's like portal venous gas. That's also very, very worrisome. That means the gas has made its way all the way up into the portal venous circulation, right? So these are the worrisome signs that you need a stat surgery for. Okay, and as we mentioned, this bacteria going to translocate into the space around the bowels, right, which is your peritoneum. So you're going to have peritonitis. It is a significant symptom or sign of a worsening colitis, right? What caused ischemic colitis in the first place, right? So this is usually a is a lack of flow to the bowel. Is a lack of flow because of a clot? Maybe, but usually that's mesenteric ischemia. It's because of like a shock state, right? A hypoxic state. So when it has an extended hypoxia, the gut's not going to get the O2 it needs. And this area, just like with our strokes, we have the watershed strokes. You have lack of flow in this area right here when we have low blood pressure or hypoxia. It's the boonies where you're not getting a lot of highway system, a lot of blood flow too. Right, so ischemic colitis is a significant cause of that is because of a lack of flow, a shock state, right? An ICU patient would be at a high risk of hypotension, right? You got a CHF patient at end stage, right? Someone has underlying coronary artery disease or peripheral artery disease, they're going to be at even higher risk when they have atherosclerosis to that area as well. Okay, so it's a non-occlusive hypoperfusion. That just means it wasn't a clot that got in the way. It was just low perfusion to that area of the colon. And that area of the colon then got ischemic and got necrotic and started dying off. And now bacteria are going to start to proliferate and make their way across the bowel if they wanted to. All right, so that's going to lead to a peritonitis, a hot belly, right, where they have a belly that has diffuse, rigid appearance, distended, rigid appearance, and it's going to be diffuse pain throughout the whole belly. All right, diverticulitis might start out in the left lower quadrant, but when it develops peritonitis, it's everywhere. Right, appendicitis might start in the right lower quadrant or in the periumbilical area halfway between the iliac crest and this, and have Rothstein sign, whereas in the left lower quadrant, but it's on the right lower quadrant, the rebound center. It could be all the things, but eventually once it bursts, it's going to then cause peritonitis is going to extend from that area, and it's going to be diffuse abdominal pain. Same thing, colon cancer. Worst case scenario, if it's big enough, it's going to eat away at the bowel walls, and then it can then cause a peritonitis. Like that will occur, where you have SIRS symptoms, you have a fever that develops, the SNS fires off, you start developing, and you have that classic symptoms of diffuse abdominal pain. Well, shoot, that's a peritonitis that has developed. Okay, so you have the colonic inflammation, leukocytosis, there's our peritonitis that will develop, and eventually if it's bad enough inflammation or bad enough infection, a very toxic or virulent bacteria makes its way to the bloodstream, that can cause systemic septic shock as a result of this lack of flow at the little flexures right there, right? And they kind of necrosed off, and you get what symptom? You get a lower GI bleed, a bright red blood per rectum, and then you start getting peritoneal symptoms. These are kind of putting everything together. Could it be diverticulitis? Well, that doesn't cause bleeds, right? If you have a bleed and you have a peritonitis, we're kind of thinking it might be ischemic colitis, especially in an ICU patient, because they are at risk for low flow states, right? What prevents this? Well, if I keep the bowel perfused the whole time with a little bit of enteral nutrition, a little bit of GI feeding, I'm going to have some flow, right? Your body's going to say, okay, they're going to reduce flow by 90%, right, to an area, right? If there's a little bit of reason to provide flow to one area, it's going to provide some flow and hopefully prevent ischemia and a stoppage of GI activity. Okay, so shock states can occur, and how do you know you have ischemic colitis? Right, you could have, when you start having severe symptoms, where you have peritoneal signs, you have pneumatosis, which you mentioned was a really, really bad sign, pneumobilia, portal venous gas. Who needs to be involved? No, GI doc's like, okay, cool. I can't do it with my scope. I'm going to go do a colonoscope in there. They will be consulted. They will go in there with a colonoscope, and they go, oh shoot, it's dusky, it's gray, right? It looks cyanotic. And that's what they will find on the colonoscopy. Will that fix it? No. Usually colonoscopies and upper endoscopies, EGDs, they can fix stuff. They can band it, they can clip it, they can take biopsies, all these things. They will take biopsies, they will see that it is infected and not hypoxic. Or will they see it's hypoxic, they'll see that it's, the tissue resembles hypoxic tissue that has died and has apoptosis. But is it going to fix the problem? No. So really we need a surgical consult, right? So a surgical consult is needed to fix this. GI will scope it. So you got a lower GI bleed, right? So they might have like really, really bad atherosclerosis and the blood pressure on the low side because they have CHF, heart failure with reduced ejection fraction. And that's what put them in this situation, because they had low flow to the gut, right? So that's the idea behind a ischemic colitis. And then what about mesenteric ischemia? So mesenteric ischemia, these sound very similar. When you say mesentery, you're usually talking about the small bowel, right? And we talked about colitis, we're talking about the colon. The colon's part of the what bowel? It's part of the large bowel, right? So we have large bowel versus small bowel. Are they caused with the same thing? No. Are they both due to low flow? Yes. So one's low flow because of a blockage, right? So they have a occlusion of some sort. They have maybe an atheroma has dislodged. Maybe that could be it. Maybe they have AFib, right? And they threw a clot, or they have a procoagulant state because they're septic, and now that has clotted off the mesenteric arteries to the bowel, right? These are both arterial insufficiency or arterial drops in pressure. But if it's a sustained drop in pressure, like a shock state, or like a watershed low BP, that is ischemic colitis. If it is a blockage, a low flow because of an occlusion, like an embolic situation where we have plaque, or we have a AFib that has dislodged itself, right? Yes, AFib can cause a stroke, it can cause a yeah, PE, but it can also dislodge the arterial system and make the first left off the below the diaphragm into the superior mesenteric artery, right? So our SMA is over here, superior mesenteric artery. You can see how nice of a shot that is. It's a super easy turn, right? It's not like a hard turn like Newhall, right? Newhall, haven't ever done that turn, right? Back in Valencia, like, what the heck? You're like making a freaking U-turn, right? So that's not a superior mesenteric artery. Superior mesenteric artery is a nice, easy 10-degree turn, right? So that's the idea behind why that's a high risk. Okay, what can happen? Can you get air in the portal circulation? Yes. Can you get air in the bowel? Yes. When bowel dies the same, right? So you're going to have this pneumatosis develop as well. Okay, do they cause GI bleed? Yes, both superior mesenteric arteries mesenteric ischemias because of an SMA occlusion and ischemic colitis, they both have GI bleeds, right? So they have this GI bleed that's happening. So mesenteric ischemia, it was because of a hyperperfusion, but it's usually because of a clot of some sort, right? So you have cardiac, you have AFib happening, you have a valve disease. These are causing a procoagulant state or a inflammatory state that's putting at risk for clots to develop. And this is small bowel, right? So it's small bowel versus large bowel. So large bowel is which one? Large bowel is ischemic colitis, right? And small bowel would be a mesenteric ischemia, or do a blockage because of something is in the way of flow to that area of the bowel, of the small bowel. All right, so how do you know they have it? Well, a CT angio is going to help, right? CT angio, right? It's with and without contrast. Do you need a contrast for ischemic colitis? No, but you can see it on CT. But CT angio will light up all the vessels, and you say, oh shoot, there's no flow to this superior mesenteric artery right there. There's a blockage on that one little branch, or even a little more proximal, right? So then they can say that that's your problem, right? That's why you have this abdominal pain. And does ischemic colitis abdominal pain? Yes. When your bowel dies, it hurts, right? But when you have ischemic colitis, when you have mesenteric ischemia, this occlusion of that vessel, it is pain out of proportion, right? So pain out of proportion of exam is like, whoa, shoot, why are they like this? What's going on? They're not going to be have peritoneal signs so much, right? I mean, that'd be very, very late. They have this really, really profound pain, just to barely touching them will make them jump out of bed, right? So pain out of proportion of exam, or poop, right? Pain out of proportion, right? You want to know what can cause that overall. And one of those things is a mesenteric ischemia, is a pain out of proportion. And you can see like compartment syndrome, right? When someone has leg swelling and you give them pain medication and it still hurts, like the worst hurt they ever had, that is compartment syndrome until proven otherwise. When you have back pain that's tearing and ripping to the back, it's extremely painful, and you gave morphine, you gave pain medications, and it's still hurting, that is aortic dissection until proven otherwise, right? We also know if we check the blood pressure on both extremities, if it's aortic, it could be that's another symptom as well, right? So we have necrotizing fasciitis, extremely painful, right? We have other otolaryngologic or ENT reasons for poop or pain out of proportion to exam. Okay, if you have this acute occlusion of the vessel, right, this bowel that's dying and dying and dying is going to produce what? Lactate, right? It produces a lot of lactate when this happens. All right, and being hypotensive is not going to help the situation. Being hypotensive slows down blood flow, and that puts you at high risk of clotting. Okay. So what else? So bowel necrosis leads to a forming of gas, right? Pneumobilia or pneumatosis intestinalis. You have gas in the walls of the GI tract, right? Of the colon or the mesentery, the small bowel. That's going to be worrisome, right? And they need surgery in either of these situations, right? They need to get in there and figure out if they need to resect some of the bowel, or they need to go in there and they need to do like IR to take out the clot, not embolize, because that's going to cause another mesenteric ischemia. They have to go in there with IR, maybe take out the clot as an option. Or if the bowel is already dead like this patient's been opened up, they're going to take out that whole piece of small bowel. Okay. So what else? So mortality of 50% on patients that get mesenteric ischemia. It's much, much more deadly compared to a patient with ischemic colitis. Ischemic colitis, they can bounce back from. So 75%, even 85% has spontaneous resolution. As we get the pressures down, as we get better flow, the colon can repair itself, as long as the bacteria didn't have time to grow and grow and grow and translocate, right? But mesenteric ischemia, you can't just cut off that clot, right? Your body's gonna do its best to break down the clot, but we need to help it out and hopefully pull out the clot, or we need to get them fixed with surgery. All right, so that's the idea behind mesenteric ischemia versus ischemic colitis, where we have bowel that is dying, one due to low blood pressure and one due to occlusion because of a clot or a atheroma has dislodged, for instance, or has exposed itself and platelets have aggregated.